All right, welcome everyone to Riverside Medical Clinic Charitable Foundation's webinar series. Thank you for joining us tonight. My name is Megan Ramos, and I am a program coordinator with the foundation. And tonight we have a very special speaker. Meghan Cleary is a wonderful champion in the world of endometriosis. She writes and speaks and advocates about a variety of women's reproductive health care issues. And we're so excited that she is here to share such an important topic with us tonight. And as a reminder, as she speaks, feel free to type any questions into the Q&A box on the right side of your screen. And at the end, I'll read those out loud for her to answer. And so with that, I will go ahead and pass this over to Meghan.
Well, everyone, thank you so much for coming. I am so excited. Oh, hi, there we are.
Oh, okay, perfect. We can see you.
Okay, great. So I just want to welcome everyone. I wanted to thank the other Meghan Ramos. I said your maiden name. Sorry about that. She runs the support group with Riverside Medical Clinic Charitable Foundation, and they do wonderful work, and I'm just so pleased that I can be here and talk to you, and just wanted to thank them for putting this all together. And it's so great. As you know, endo girls, sometimes we can't get out of bed, so it's really nice to be able to tune in online and get some support that way. I'm really excited about what I'm going to talk to you about. I myself am coming off about a 10-day, pretty crazy endo flare-up, so I'm right in the midst of it with all of you. So we're going to just bear with me because I'm not 100% totally on it with the WebEx technology, but we're going to go over to my presentation, and here we are. Can we all see this? I hope so.
Yes, it's perfect.
Okay, great. And do you see me as well, or do you just see this screen?
No, we see you too.
You see me and the screen?
Yeah, it's perfect.
Oh my God, double trouble. Okay, great. Well, all right, guys, I'm just going to jump right into it. So this is called, it's got a long name because we have a lot to cover. And I'm going to talk pretty quickly. I'm going to roll through highlights. I'm not going to go through every single point on every slide. I'll kind of leave it up there so you can read it. And then we're going to do some questions at the end. You can, I think, type them in, and Megan will read them out loud, and I will answer them. So this is, like I said, it's a long title, but it's an important one. So it's Why Won't My Insurance Pay for My Endometriosis Excision Surgery? This is really about how clinical gender bias delays our diagnosis and treatment and what we can do about it. Whoa. So who am I? My name is Meghan Cleary. I am a writer, I'm a speaker, I'm an advocate for women's health and endometriosis patients. I had a delayed diagnosis of 31 years, and I'm also what's known as a DES daughter, which means my mother was given a drug called DES while she was pregnant with me. It was the first endocrine disruptor ever introduced into the human and farm population in the United States from 1938 to 1971. And DES daughters and granddaughters, so if your mother took it while pregnant with you, or even the granddaughter, we have much higher rates of endometriosis, fibroids, and a whole bunch of health issues. You can go to DES Action if you want to check out more. And even for moms who didn't take DES while they were pregnant, it was given to farm animals, lots of chickens during that time. So a lot of women who were childbearing age were eating it, even though they didn't know that. So like I said, I'm a writer, I'm a speaker, I'm a patient advocate. I could talk to you about so many things endometriosis related, including endocrine disruptors. and including treatment plans, and including what to do post-surgery, and including how to advocate for yourself, which we're going to cover a little bit in this presentation. But what I want to talk to you about today is clinical gender bias and how that delays diagnosis and treatment for endometriosis patients in particular. So, what is clinical gender bias? You may have heard this term thrown around. You may have never heard it. And basically, just to sort of break it down to its simplest form, clinical gender bias is really, it's a way of thinking by healthcare practitioners, doctors, scientists, and institutions about women's bodies and their health. It is a consequence of a lack of studies, research studies, and clinically evidenced research on women's bodies and our biology. And it's a product of old cultural ideas, myths, or other erroneous beliefs about women's bodies. And unfortunately, it results in delayed diagnoses, dismissal of symptoms, and can cause physical and psychological harm for everything from heart disease to maternal health and everything in between, which we will go into. And I want to be really clear about clinical gender bias. I'm really about facts and evidence-based medicine. I really like facts. So this is not about sexism in medicine per se, or discrimination per se. It's really about actual facts of what we actually scientifically know about women's bodies and how that comes to be. So just a few quick facts. Before 1991, medical studies on diseases, medications, diagnostics were not required on women by the National Institute of Health, and that is the governmental body that sort of oversees research on health. So most clinical studies were being done on white men. Before 2008, pregnancy was considered a pre-existing condition, and if you planned on becoming pregnant and you wanted your insurance to cover prenatal and maternal health, you had to actually pay more. So you were discriminated against if you were going to have a baby. Before 2011, virtually nothing was known about how heart attacks present differently in women. In an emergency room, it takes a woman on average 45 minutes longer to be treated for severe pain than a man. And again, everything I'm going to go through in this presentation is all factual and researched. So if you want, you can always email me at the end. I can send you a bunch of links to find out more about all this information. Depression, lung cancer, and Alzheimer's all present differently in women. And in 2017, the U.S. had one of the highest rates of maternal mortality in the industrialized world, with women of color experiencing triple that rate. So these are just a few little flash points I'm going to share with you. This is an article from ABC News in 2011. I'm just going to read you the first sentence, which is, the most common way women present with heart disease is dead on arrival. And that's a quote from Kathy Magliato, who's a cardiothoracic surgeon in Los Angeles. And what that says is that this is when they were just coming to know that heart disease presents very differently in women and men. It presents sort of as a big event. It's a big pain and it's a big event. Women have different arteries, and actually heart attacks present much more diffuse. So they have totally different symptomology, and they present very differently. This is an article from the New York Times, 2014. This is a scientist. This is an article about how they're actually starting to fund gender bias studies to make sure that female biology is also being studied. And so this is a doctor who literally said, we just know less about every aspect of female biology compared to male biology. And that would stand to reason if there's only scientific studies on male bodies. This is from a report, I think this is 2010. Brigham and Women's Hospital issued a huge report called Women's Health Can't Wait. You can read all through this, but basically not included in clinical research, in early stages of scientific discovery about diseases, sex is not considered, and a lot of safety concerns when it comes to prescription drugs. The most known one about that, obviously, is Ambien, which was on the market for something like 8 years before they discovered that women really should be taking half the dose of Ambien that men should because of the way they metabolize it. So here we go. So if that's the landscape for regular diseases, then what do you think happens when we get to something gynecological? This is what I call the gyno ghetto. There is a severe, steep drop-off in clinical evidence, studies, scientific knowledge, actual peer-reviewed publications, all in the quote-unquote gynecological realm. So what does that mean? If you have a disorder or an illness or condition that manifests in symptoms associated with your period or with pelvic pain, and that can include anything from endometriosis, fibroids, PCOS, adeno, interstitial cystitis, you fall very quickly into the gyno ghetto. And this is not a great place to be because I said, like the lack of clinical evidence. And periods carry with them an added weight. There's a lot of cultural stigma, shame, taboo, embarrassment. Women are sometimes embarrassed to report the symptoms. They might believe there's a cultural belief that it's their lot in life to have pain with their periods. Women don't know the name of their body parts. They don't know how to describe what's going on. They may have felt that they've done something to cause the symptoms. And unfortunately, most healthcare practitioners do not have the right tools to diagnose and treat these disorders effectively because of the lack of all the information. And they do not give these type of disorders or illnesses adequate time and attention. And there's often a dismissal of women's pain, or they try to suppress women's pain. So what does this mean for endometriosis patients? Well, it kind of starts with the actual definition of endometriosis. Endometriosis is not endometrium, which is gotten loose from the uterus. It's not a result of retrograde menstruation, and it's not a disease of the uterus. All of this old thinking echoes way back to the ancient myth of Hippocrates' wandering womb theory. And it really, this incorrect definition of endometriosis perpetuates a lot more clinical gender bias. And in the absence of scientific and clinically evidenced knowledge and correct definitions, what happens is a lot of myth steps in to take its place. So institutions that continue to say that this is the definition of endometriosis, that is wandering uterine tissue that has gotten lost from the uterus, include like the Mayo Clinic, Flutter Health, the Clue Period Tracking Application, Active, WebMD, UCLA, and many, many other places. And I'm sure if you do a quick search on what is endometriosis, this is the definition you'll see. Now, of course, there are a few sites that are actually giving the right definition. They include Vital Health Institute, the Endometriosis Foundation of America, Center for Endometriosis Care. So there are people out there who are putting the right information out. So because it's period related, a lot of people think we can just suppress the period, suppress the disease. And by making endometriosis about a woman's period, it allows practitioners and institutions to dismiss the disease by saying it's just bad periods, this is not a larger disease, it doesn't require anything more than giving a pill, it doesn't deserve our full attention because it's period problems, which every woman has, period cramps are normal, I think we've all heard that one, and all these myths just delay diagnosis because it's thought of as just bad periods. So unfortunately, these myths drive a lot of the treatments, like the ones currently recommended by the American Congress of OBGYNs, They're called ACOG and followed by OBGYNs. They're the professional society that oversee the 54,000 OBGYNs in this country and set out guidelines for them of how to treat women. So without more evidence-based clinical definitive research that includes women, these myths are going to continue. Diagnoses are going to continue to be delayed, and ineffective and sometimes harmful treatments will continue to be deployed. So wait, let's just back up a second. What is endometriosis? Endometriosis is a disease where cells similar to those that line the uterus, not uterine lining, are found throughout the pelvis and sometimes in rare cases in distal sites outside the pelvis, like the lugs or the brain. So they can really be anywhere in your abdomen, your pelvis, your bladder, your colon, your rectum, yes, your ovaries and uterus, even though only 3.7% of women have endometriosis in their uterus or ovaries. These cells, they land kind of scattershot, like if you dropped a handful of sand all over the inside of a person's pelvis, that's kind of what it looks like. And these cells effectively act like hundreds of blisters all over the pelvis that get turned on at the advent of a woman's period because of hormonal changes. And there's new research that shows that these cells in many ways are similar to cancer cells, but for whatever reason, they don't mutate into full-blown cancer. So in many ways, endometriosis is like having a non-terminal cancer of the pelvis. And just to be clear, it's not a disease of the uterus, and removing the uterus alone does not treat it. The cells are not endometriosis, endometrium of the uterus gone rogue. And there are many new findings that show endometriosis has autoimmune aspects to it. So if you think about it, it's really a disease or condition that shows its symptoms in painful periods as one of the symptoms, but it may not be a period problem. So right now, endometriosis is pretty poorly managed at best by both clinicians, sometimes with treatments that actually can do harm. Most OBGYNs are not trained to identify endometriosis in all of its forms, which can be red, clear, blue, yellow. They are taught only when they go inside to do laparoscopic surgery to look for quote-unquote powder burn, which is sort of a brown powder burn substance that we're learning now probably isn't even endometriosis cells, but they may just be old blood from old cysts that have burst. OBGYNs are not trained sufficiently in gynecological surgery. The focus is mostly on baby delivery and hysterectomy, which is a fairly easy surgery to perform. OBGYNs are generalists, so that means they do a lot of different things during the week. They may deliver a baby on Monday, they're taking out fibroids on Tuesday, they're doing pap smears, they're doing well woman exams. So most OBGYNs are just not specialists. They don't deal with endometriosis all day, all night. They deal with a whole bunch of different things. And again, these are all facts about medical school training, and I can give you links and sources if you want to email me later. So basically, ACOG, our friends at ACOG, that's the American Congress of OBGYNs, they only offer what's called palliative treatments. That means treatments that don't actually remove the cells and don't actually treat the disease. So what they recommend is a laparoscopic surgery where you burn off the cells, hormonal suppression, or hysterectomy. But they themselves say that none of these actually treat the endometriosis, remove the cells, and the significant dense adhesions that can form in an endometriosis patient's pelvis and actually adhere organs to each other. So just to go over it, their treatment guidelines are not really based on current clinical evidence. They're on very outmoded concept. Their burn it is really like burning a piece of meat with a creme brulee torch. It can cause a lot of problems to other organs if you imagine what it's like to burn something like that. And there's so many organs in your pelvis so close together. There's also suppression with hormones, birth control pill, and hormones like Lupron. They also recommend cutting out your uterus, which some people refer to as castration. I do not like that word particularly, But they also say in their guidelines that if burning or suppressing treatments don't work, their definitive treatment is removing the uterus. None of these treatments have been clinically evidenced to remove endometriosis lesions or adhesions effectively. Birth control pills have been clinically proven to cause depression, especially in young girls, in a recent landmark study of over 1 million women. Lupron was originally created for end-stage prostate cancer patients. It can cause permanent ovarian failure and joint and bone damage permanently. And removing the uterus doesn't cure endometriosis because endometriosis is not a disease of the uterus. Wait a minute, are all hormones bad? No, hormones are not bad or good in and of themselves. So they might work for one body, they might not work for another. So they may be a great option for you to manage your symptoms. They're not going to cure the endometriosis and they won't remove the cells, but they can be effective in managing your symptoms. They're also not the only tool. There is surgical therapy in the form of excision. There's pelvic floor physical therapy, diet, acupuncture, functional medicine, meditation, pain management programs, exercises. These are all different examples of tools that can be used as well, and you can use them in conjunction with hormones or not. And management of endometriosis is a personal choice, and how you do it is up to you. The important thing is that you as a patient are 100% informed of all the side effects and all the evidence and the research, so you can make the best choices for your body. Wait, is hysterectomy bad? No. Having a hysterectomy is not bad or good either. Now, the facts are a hysterectomy alone will not remove endometriosis because it's not a disease of the uterus. However, when it's paired with excision surgery, it can provide relief. And there's another condition called adenomyosis, which is tissue similar to endometriosis cells, but it's embedded in the wall of the uterus. And so it can cause a lot of pain. And so adenomyosis can be relieved with hysterectomy. But we have to remember, is most women who have adeno also have endo. So it's important to find a specialist who can remove the endo also. It's also important to understand what's a partial and what's a full hysterectomy, all the risks and outcomes. Got to make decisions based on your body, your informed consent, and your quality of life. It's all about you, which we'll find out more later. Okay, I want to introduce you to this. This is the World Endometriosis Society's sort of overview about how endometriosis should be managed. Now, I bet you've never seen this before because no one in America seems to really use this. So what's interesting about this is that they put at the center of managing endometriosis the woman and the gynecologist together. They are the decision-making team. And they go to all these different people to help them. So they may be surgeons, they may be complementary therapies like acupuncture, patient support groups, nurses, psychologists, massage, acupuncture. So you see, this is a very different treatment model than what ACOG recommends, which is just sort of go in there, try to burn it, try to suppress it. This is more about a comprehensive pain management. And this is the only clinically evidenced, up-to-date model for management of endometriosis. Okay. They also say that patients should be treated at a center of excellence. Now, what does that mean? So they're saying that you should go, if you're going to go and you're going to have surgery, you should have surgery with a person who has specific training in endometriosis. So like I said, OBGYNs in their regular training, they don't get specific training in endometriosis. They're saying you should see surgeons that have a high caseload of managing endometriosis and deep infiltrating endometriosis, and that this center should have an endometriosis organization. They should be doing a lot of research, etc. Now, there are very rare, very few of these centers of excellence in the United States and really around the world. So, in essence, you kind of have to put together your own center of excellence. Now, of course, there are are some in the United States. One of them, of course, Vital Health Institute. Full disclosure, I had my surgery there, my excision surgery there, and this is one of the reasons. So you really have to research your surgeon. You can ask these questions. You can use this model. You can say, hey, are you guys into this? Again, do your research. So here's a big question. What does this all have to do with insurance? Well, insurance companies they really don't know the latest clinical evidence, and they're also subject to clinical gender bias across many diseases. And what they do is they rely on professional societies to issue the guidelines that they can follow. So when you try to go get your surgery, they will turn to the ACOG guidelines, which ACOG guidelines say, no, you should just burn it and suppress it, and that's fine. But the real modern clinically evidenced criteria, as we saw, is the World Endometriosis Society. So when you want to go have surgery with an excision specialist who does high volume excision surgery, you, the patient, are going to have to be the ones to bring the World Endometriosis Society criteria to the attention of the insurance company. And you can do that through a single case agreement appeal. All right. This is all super depressing. And yes, it is kind of depressing. But I want you to know, and it is a little depressing about where we are right now. But there are so many growing movements addressing all these issues right now as we speak. Maya Dusenberry just had a new book that came out today called Do No Harm, that's all about clinical gender bias. Shannon Cohen, who did the documentary Endo What, which if you haven't seen it, must see it. She's doing some work with Senators Warren and Hatch. Casey Berna has a petition and direct actions that she's doing to petition ACOG to revise their clinical guidelines, and a ton of clinicians have signed on, as well as a huge amount of international organizations have signed on to that petition. Jordan Rosenthal, the journalist, doing a great series on hysterical women in medicine on Medium. Jennifer Weiss-Wolf is, she's a great author. She just wrote a book called Periods Gone Public, and if you Google menstrual equity, that's her term. So women are really speaking out and demanding change from these institutions who are supposed to care for us, and they really have a lot of embedded gender bias, but people are speaking out. So what can you do? This is what it's all about. I'm all about practical actions that you can do right now. So the first thing you can do is change your thinking. So your body is worth getting the right care, your symptoms are worth addressing, and your quality of life is important. So for many years, most women experience a diagnostic delay of about 7 years. And during those 7 years, you might have been told a million times that you just have bad periods, your pain has been dismissed, you've been in and out of the ER, dismissed, not heard. So after a while, it really gets to you, and you start to think, well, maybe there's something wrong with me, and I just can't fix it, and it's not worth trying anymore. And I'm here to tell you that it absolutely is. Again, your body is worth it. Worth the right care. Your symptoms are worth addressing, and your quality of life is important. So the first step you can really do is change your own thinking around that. The other thing to remember is there's no one solution to managing endometriosis. There is no cure. It is a chronic illness or disease or condition, however you want to term it. So you have to put together your multidisciplinary team and decide what is best for your body. And we need thriving, healthy women like you to meet the demands of our time. All right, here's some more practical actions. Number 1, you must write all your symptoms down and print them out before you see any health care practitioner. Why? This is so crucial and so important. I can't emphasize this enough. So many times as endometriosis patients, we walk into a doctor's office, we're beside ourselves, we're in so much pain, and we just say, we're having pain, and please help us, which is perfectly viable to do. And in the perfect situation, a doctor would ask you leading questions, he would do a complete exam, he would ask you very specific questions, he would do pain mapping, he would chart your symptoms and all those things. But that's not happening. So you actually need to do it for yourself. So before you go into any medical appointment, I want you to write down every single symptom you're having. Now, this does two things. Number one, it validates all your symptoms to yourself. And number two, you need to present clinical data to your practitioner. And that means putting your symptoms into data. So you got to learn your vocabulary words for your pain. What kind of pain is it? Is it burning? Is it tingling? Is it piercing? Is it stabbing? Google words for pain. There are many, many resources. How many days, how many weeks per month are you having this pain, and at what levels? You need to learn the words for all your body parts and show the doctor on your body where your pain is. And you need to draw where your pain is on your body on a piece of paper and bring that with you. And what a really important thing to do is to keep it out of it's just your period talk. So talk about pain management, chronic pain, managing symptoms, organ dysfunction, your deep fatigue. Talk about it in those terms. And what is extremely important is when you go into the doctor to print out one list for yourself and one list for your doctor and insist that they scan this into your electronic medical record. Now, the reason for this that's so important is that often doctors' notes about your conditions are completely subjective. So what that means is their notes about what you're describing to them in the meeting is going to be informed by clinical gender bias. So if they're a person that doesn't take women's pain seriously, they may write things about your pain that diminishes the pain in your medical record. Everything goes through their lens. So this is a way to put your symptoms that you are reporting from you in your medical record. And you request, you say, I would like to have this scanned and entered into my electronic medical record. That way it's in your medical record, and anytime you go anywhere or you're asked for your medical record, it's going to be in there. Okay. What else can you do? It's very important you either find a therapist or an endometriosis buddy that you can process all the trauma of not being seen and heard by our medical system and share your plan for managing your illness. So, we go through a lot as endometriosis patients, and especially if we've been told over and over we just have bad periods, or nothing's wrong with us, or they can't find anything wrong. Just because they can't find anything wrong doesn't mean that there's nothing wrong. They simply do not have the tools. They don't have the scientific research. They don't have the knowledge. They haven't been trained. So, but it doesn't mean that you're not having the pain, and it doesn't mean that there's nothing wrong with you. My primary care physician is a great guy, and he is not an endometriosis expert at all. He doesn't know about endometriosis. I have taught him so much over the years about it. But one thing he would always say to me is, Megan, we don't know where this pain is coming from, but you're having pain and we got to try to figure it out. So even though he didn't know about it, he was willing to acknowledge it. And it's also really important to share stories with others. And it's also important to be upfront with people about that you have a chronic illness, that your energy is really up and down. You might want to do stuff, but you can't. You would love to, but you can't. And talk about your symptoms with people who aren't familiar with endometriosis, again, outside of the period realm. So I have chronic pain. I have tons of little blisters inside my abdomen. I have deep fatigue. These are ways that you can sort of talk about your experience to other people and connect with them, whether they have endometriosis or not. But it is very important to have an endo buddy in your world. We all need them. Even I need them. I had to call one of my favorite endo buddies this week or last week and have her go through everything with me. I should show you my new plan, which I taped up on my wall because I've been going through a pretty bad flare lately. All right. You can also become an activist. You can sign Casey Byrne's petition. You can write to her and ask her how you can help. You can challenge conventional gender-biased thinking in conversation with other people. You can organize meetups in your town or city. It's Endometriosis Awareness Month. You can participate. There's marches going on and all kinds of events if you type in endometriosis awareness. So I want to kind of bring it home to the bottom line, which is it is so exhausting to have endometriosis. Between the pain, the fatigue, the financial burden, it's so much that we have to manage. It's not fair that the burden is on us to also manage our treatment and also manage the scientific evidence and present that to our doctors. But just remember, you don't have to be marching in the streets. You don't have to be political or ascribe to any political party to make change. Every time you take your symptoms seriously, you get your doctor to take your symptoms seriously, you are making it better for the next woman who comes along. So that is really my presentation, and I'm going to go to the resources page. Now, all these resources, they're also all on my website, which is bad-periods.com. So I have information about both fibroids and endometriosis on my page. It's really, my website is very simple and very straightforward. It's all the answers to all the questions I wish I had when I first got diagnosed. I literally just wrote them all out. So it's all right there for you. If you put your email in, I have I call it a treatment guide, but it's really just a way to write down all your symptoms like I talked about to bring to your doctor. There's great websites out there. All of these websites are wonderful. And then the World Endometriosis Society Consensus on Endometriosis Treatment. That is a paper that it would behoove you, if you can, to print that out and bring that to all of your doctor's appointments, because it's full of clinical data and it's a great paper written by a lot of clinicians, and you've got to educate people as you go along. That's endometriosis for you. So anyway, I guess we go back to this page, and Megan, I'll just ask if there's any questions.
Great, thank you so much. So if you guys go to the right hand of your screen, there's a Q&A, and you can just type right in there, and I'll read them. So I'll go ahead and read the first one. At what point were you able to go from just suffering from endo to speaking out about it and helping other women? How were you able to do that?
Oh my God. Epic journey. So I had endo for 31 years, and I went to get a fibroid removed. And I researched my surgeon, and I was really, really on it. And it turned out he was great at removing the fibroid, but he wasn't trained in endometriosis. And so he actually did the burning thing inside me. And so about 6 months, a ton of pain, more pain than I've had before. And I started to get crazy symptoms in addition, like migraines and all kind of things. And I went into a movie theater one night to see Endo What, which is the documentary Shannon Cohen directed, and realized that I had never been diagnosed since I was 14, that I probably had endometriosis, and that I needed to get excision surgery to get the rest of it gone. And I came out from that experience. I had excision surgery with Dr. Cook at Vital Health Institute in September of 2016. I had a very long and hard recovery, and it's only been in the last 6 months where this experience transformed me in such, I'm going to get emotional, but in such a deep, deep way, because after not being heard for so long and then finally understanding what I had, I realized how hard it has to be for other women that don't have access to the resources that I have. I live in Los Angeles. I live in a major city. I have access to the best healthcare in the world. In California, I have health insurance. I speak English. I'm white. I'm highly privileged. And so I just realize every day that it's so much harder for people who don't have what I have. And I also have an incredible community of support, an incredible family, friends, and access to resources that other people don't have. So that's a really long answer, but in terms of how long it took me, you know, it's funny, I was always talking about my period from a long, long time ago, since I was like 14, when it was like, don't talk about that. Don't talk about your period. No one wants to hear about that. Don't talk. And I was always like, I don't understand. Like, this is the thing that's happening to me, and I'm sick, and I don't feel good. Why can't I talk about it? You know, people talk about when they have appendicitis or they have something wrong with them or they break their leg. Why can't I talk about it? So I've always been talking about my period. But it's been the last 2 years and then really the last 6 months where I finally had excision surgery. So I don't have periods where I'm on the floor on all fours and I don't have these uterine cramps. I mean, I just like laugh now because I don't have uterine cramps anymore. It's almost hilarious to me because now I understand why other girls could do so many things during their period. I still have to manage endometriosis, and I still have to manage my life, and I still have to manage my energy. But I feel like in the last 6 months, there's been a huge sea change in the world about what women are willing to put up with. And I also feel like I have the knowledge and I have the ability to talk about it and communicate with other women. And it's just become a driving force, I would say, for me probably in the last 6 months.
Great, thank you so much.
Long answer.
That was wonderful. So our next question is, you spoke about misconceptions about what endo is. What language do you use to describe endo to someone who has no idea what it is? For example, a parent or a boyfriend.
Okay, this is hilarious because I test drive. So I used to work in marketing for a really long time. So what I do in marketing, what you do is it's called developing messaging, which is like, what's your main message you want to get out? So I kind of developed a couple sentences where I describe, and I literally talk about it to all kinds of people. So cab driver will pick me up. I'll start yapping to him about it. I talk to doctors about it this way. I talk to insurance companies. So basically the way that I describe endometriosis is endometriosis is a condition where when you're forming in the womb a whole bunch of cells that are supposed to form and do other things, maybe they're supposed to form your bladder or your bowel or whatever, for whatever reason they don't, and they just land kind of scattershot all over your abdomen. And for women, when they get their period, for whatever reason, these little cells are turned on. And in essence, it makes it so your entire abdomen and pelvis is filled with hundreds of tiny blisters. And it causes, obviously, a lot of pain and a lot of fatigue, and it's really hard to manage. And that's how I usually describe it. Some people will go a little further depending on if they're like, oh wow, that sounds so intense, and they seem like they're receptive. I'll say, it really acts in some ways like a non-terminal cancer, and it's a chronic illness. It's really important to tell people about chronic illness and to say, even though I look okay, tonight's a perfect example. I put on makeup and I look okay, but 2 days ago I was in bed all day. So it's really important to tell people chronic illness means you have really up and down energy and you don't know when you're going to have good energy. So if I can't do something or if I can't be there, it's not because I don't want to. It's because I'm not able to. And I think if you impress upon people, I do get a lot of times I just talked to you yesterday and I would have had no idea. And I'm like, yeah, well, there's a lot you can do from bed in your PJs, So that's really, I think if you can describe it that way, people start to understand it. And especially if anyone has had any experience with chronic illness or cancer or any other illness that's kind of a big life changer, people usually get it.
Great. So our next watcher says, thank you for being a voice in this very real and very undertreated disease. It is sad to know that it takes an average of 12 years for a person to be diagnosed. It's heartbreaking. Please keep raising awareness and please continue to teach and spread the word.
I will. And you too, my friend, whoever you are.
And then we have another question that says, how did you go about finding an endo buddy?
Oh, what's so funny is I've had a couple really great endo buddies. One endo buddy I found on a Facebook group called Endometriosis, which is a great Facebook group. They have a lot of great clinical evidence. There's also Nancy's Nook endometriosis support group. Both of them, one of them is run by a researcher and one of them is run by a nurse. So they both have a lot of great clinical information. But I met a woman on endometriosis who was having surgery with my surgeon the week after I was. And so we actually met up in person before our surgeries. And then after surgery, we were text buddies with each other. And it just made such a huge difference. We sent yellow roses to each other in the hospital and all that. And it made such a huge difference because just to be able to text someone and be like, oh yeah, post-surgery stuff is really crazy. And, to be able to just text someone who knows what you're going through. One of the things I remember is telling her, everyone keeps asking me, are you anxious? Do you feel anxious? And I'm like, yeah, I'm fucking anxious. I don't know what my body's going to do next. I have no idea. Yes, that can make you anxious, So we would laugh about stuff like that. So it was really, really helpful. And then I actually have met some great people through another endo buddy of mine is, so Casey Berna is actually she's also a social worker, and she helps people, she's a licensed clinical social worker, and she helps people who are going through the journey of figuring out getting diagnosed and stuff. And so I actually worked with her before surgery, in a professional capacity, and then we became friends, and she's a great endo buddy. And then I've also met some women through some of my advocacy work that I do, helping women get their insurance to pay for their surgery. And it's funny because every single one of these women I feel so close to, and some of them I've developed really deep relationships with, and it's just been really wonderful. So you definitely, I guess in terms of tips, is just just reach out. You can find, there's so many people that have it. There's tons of people on Endometriosis or Nancy's Nook, and You can just say, like, is anyone willing to be an endo buddy with me? I just had a surgery. You can tell a little bit about your history and say, I just had a surgery, or I haven't been diagnosed, but I think I have it, or, wherever you're at in your journey, see if they're in your town. If they're in your town and you can meet with them in person, oh my God, it is amazing. So use a platform like meetup.com or something like that and reach out and say, hey, does anyone want to come and get together? That would be my advice.
Great. So our next question is, are you optimistic for the future of endometriosis and insurance? Is it going to be this hard for a while?
Well, I actually am really optimistic, and it's because there's such an upswell right now. There are so many people speaking out about it. I think in terms of insurance and endometriosis in particular, I do think it's going to be a little bit of it's going to be a little bit of time. But I think the more people that do single case agreements and say, I need this surgery, and present, the criteria from the World Endometriosis Society, I think it's going to start to be like, wait a minute, we keep seeing these, or wait a minute, what is this? But I think more change has to happen at a higher level, a structural level, where we go in and we educate CEOs or the people that are in charge of women's health at insurance companies and say, hey, this actually, what's interesting about excision surgery and a multidisciplinary approach is it actually saves insurance companies money, but they don't know that yet. So I think that if you went to insurers and said, hey, look, you can have a pelvic floor physical therapist, and you can have an acupuncturist and a nutritionist and a surgeon on staff, and you're going to get your patients well, the members that have your insurance well, and it's going to cost you less money. I think that's kind of the next step that has to happen. But I will tell you, it is absolutely doable. It is 100% doable to get insurance to pay. The main thing with insurance is they plan on you giving up. So as long as you don't, you're in a good position.
Great, thank you. Did you want to share your email real quick, just in case anyone has any other questions?
Yeah, so if you want to email me, it's Meghan, MEGHAN, at bad-periods.com. And my site, again, is bad-periods.com. And my email is on that site also. There's only like 4 pages on that site, so it's not hard to find. And, and feel free to email me. I can send you any of these resources. I can send you the presentation and whatever else you need.
Great. Thank you so much. So we just want to give a big thank you to Meghan for being with us this evening. And as always, a recording of this will be up on our Facebook page and will be emailed out. Our Facebook page is Endometriosis Family Support Group, and we post a bunch of other great resources up there too. So please follow and share. And a big thanks again to Meghan. This was wonderful, and we hope that everyone can join us again for our webinar next month.
Awesome. Thank you so much, Meghan, and thank you guys for doing this. And like she said, check out their Facebook page. They've got lots of great resources, and hopefully I'll see all you people soon.